So,
Right, good evening, everybody. Welcome to the MFEN lecture for this evening. We're on the 28th of April already. Who could believe it? The year does seem to be going by very quickly. Right, so having done before Easter the risk assessment stuff and then a bit on writing policies, this evening Marianne Jenkins is going to tell us about how to write a standard operating procedure. You'll hear these referred to an awful lot, and people just toss out, oh, you'll need to write a SOP. And if you don't know what you're doing, it can be very intimidating. So fortunately for you, Marianne's going to teach you how to do it before anyone demands you do it. Marianne.
thank you very much. Thanks for inviting me to talk this through with you. And it's one of those necessary evils, I think, and it'll hopefully sort of pull together some of the work that you've been doing already around risk assessments and policies, and get to see why we need them and why it's really important in the emergency department. So, just working through some of the standard information that we've got in the slides. These are the rules that I'm sure you'll be aware of from attending previous webinars from FEN, and that you are able to ask questions, and we can see how we go as the evening wears on. So basically, what I'm going to cover off as part of this talk this evening is why would you need a SOP? Why do you need a standard operating procedure? What is going to be the purpose of it in your department? What you're going to gain from having it, how are you going to write one? And there's a couple of tricks in that, and I'll talk through as the session goes on about one I've done recently and why that might be a tricky one and how I'm going to tackle it, because that's usually the challenging bit. And then how you get everyone to take it on board, and what would happen if you didn't have one in place, what is going to be a problem. So hopefully by the end of this session we would have covered off all of those aspects, and it'll be a little bit clearer, and you'll all be really keen and excited, and you'll be writing SOPs left, right and centre, and your A&E department will be running really smoothly. If only it was so easy. Okay, so what is it? So a standard operating procedure is quite simple. It sounds complicated, and we say, oh, we need a SOP for this. Well, basically it's a set of instructions that's going to tell you how to do something. It's a bit of, how to complete a task. So procedures generally are our tasks. And when you're looking at a standard operating procedure, it's how you're going to get a group of people to follow a process or procedure for a group of patients usually, or a particular type of problem that you've got a level of which you want it always reenacted. This is the minimum of how you do this process, how you do this procedure, and there's got to be clear responsibility within there. So it's usually, instead of a procedure, if we think of things like the Royal Marsden Clinical Procedures book, which currently my laptop is sat on, that's quite a weighty book, and it looks at how you're managing individual procedures, so how to catheterize a patient. So that would be your procedure. But actually, if you're looking at a group of patients or a group of people that may be involved in catheterization, then it will end up being more of a SOP, where you're looking at, this is the level that we're expecting in our department or area or wherever you're working. And it is very much that instruction manual bit that goes with it that makes it more SOP related. So just to sort of put a bit of context, this is my little bee that's in pain at the moment. So you would have an organisational policy on pain assessment and management. So that would be your overarching organisational mission statement on, this is how we're going to manage our pain assessment and management of patients. It'll talk about our philosophy of care and how we want good standards, that type of level of writing and strategy often. And underpinning that, what you often find there is the standards to say that, so say for an emergency department, we'll have standards on pain management. So everybody would be assessed regarding their pain as soon as they come into the A&E department, and we reassess within an hour. That's one of our sort of audits that you'll find that's out there. So you can see how your overarching mission statement then translates into what levels, how we're going to do that, what's our focus on within there when you're looking at standards. Oh, Let me just move this screen slightly so that you can see my other little clue that's underneath there. So then if you're having processes and procedures, then it will tell you how you're going to do that. So you'll set a standard that says everybody should be asked what their pain level is at triage, and it should be reassessed within an hour of giving analgesia. So your process then would be the nursing staff are enabled to give paracetamol for moderate pain or mild pain, and that would become how your processes then work within there. But if you're going to write a SOP, that might actually start saying our standard of operating procedure regarding multidisciplinary pain management in the emergency department means that we've got key responsibilities for pharmacy to make sure that the drugs are delivered and available in the various areas that the staff need to be dispensing it, that the triage nurse is trained in giving PGDs or is an independent prescriber, that annually everybody is given an update on managing pain assessment and is aware of all the different various tools, that we have a policy for or a process for escalating if patients' pain is outside the gift of us to manage within the emergency department. So things like if they needed a PCA, then who's got roles and responsibilities. So that's where your SOP would start fitting into your policy, your standards and your processes. So you start then bringing it together to say how you're going to do that task and how you're going to do it as a group. And then you'd have a guideline, and your guidelines would say within there, pain assessment happens in this way, and we suggest that you give codeine for this type of pain, or you give morphine based for this type of pain, and they would give guidance. But that would mean you would apply that if that fits the patient that you have in front of you, but actually it does give you a bit of scope to use differences in there, because it's not always set in stone in quite the same way. So the purpose of doing this is to get you to understand where a SOP would fit into all of these different things, because sometimes they all sound the same. You know, we've got a policy on this, we've got a standard on that, we've got a process, we've got a SOP, we've got a guideline, and they all, while they all interlink and cross over, they do serve a different purpose. And certainly if you want something to be enacted in a regular fashion, if there is a task element to it and groups of patients and groups of staff involved in it, then a SOP is usually your safest and easiest way to go to set the standard of what you want to happen regularly and consistently. So this gives us a bit. So why do we have them? So I've already alluded to some of this when we talk about we have them because it gives you clarity on what you should be doing, when you should be doing, how you should be doing it. It is an instruction, it's a task orientated, and it lets you know clearly what your individual role is within the department and who should be doing what. So while you may not necessarily have an audit function that comes with a SOP often, because they often come out of policies and guidelines and standards, but within a SOP it does give you an idea of who really should be taking responsibility for key aspects of this procedure. They are written quite often with a safety mind in. The one I'm going to talk through later on is very much about patient safety, and it's looking at responsibility of doing that. So you would want to write a SOP where it's actually going to be there to minimize risk, because you're not going to get variation in the procedure or the process that's being followed. So everybody that comes in with a pain problem will get treated in the same way, and the same assessments and the same other overarching policies and procedures will be put into place as part of it. And that's then the consistency. So it does work the same all the time. It does give you a little bit of regularity with what you're doing. It does then take all that risk out of it, because everybody should know their roles and responsibility with there. And they usually form part of that wider syllabus of when you're looking at inducting new staff into the department or making sure that they're aware of what their roles and responsibilities are. SOPs tend to fall into that part of the induction. Some of the work that I'm currently doing in our local department around pulling all our guidelines and pathways and everything back together, that this process is really helpful when you've got SOPs that are part of it, because it does tie in everything so that people know where to look for, so that they understand what they should be doing with various aspects of the healthcare that we give. And in an emergency department, it's so vast, it's very difficult sometimes to remember everything of what you should be doing. So having something that you can fall back on that just reminds you, particularly if it involves working across multidisciplinary, if you've got an agreement of who's got what responsibility for patients, it makes things much safer for patient care. So a good SOP should be written in simple terms and clear language. Now, there's aspects of the language that I'll talk through when I talk through the one that I've written recently, because language, I think, is, is really powerful, and how you then use that in the SOP makes it either work really, really well, or actually doesn't work at all, because nobody's got any idea of what you're talking about, really. So it is really important to get the language that you're using clear, and that everyone understands what their role is within it. So you don't want to be writing something that's overly complicated. It's not an academic piece of work. It needs to be referenced, but it does need to have some clarity within there, and not one of my usual very long convoluted sentences that I write just to try and blind my tutors with my knowledge that the sentences don't always support. You want to have clear defined processes and procedures within there. So historically, I have a reputation for being somebody who loves processes, and I love a flow chart. I love having something visual to support what you've written down. So actually, a good SOP should have a bit of a visual map of what it actually means sometimes. So I often think when I'm writing documents like this, or policies or guidelines, if it was 3 o'clock in the morning and I was a junior nurse or a junior doctor, I'm a bit bleary-eyed, I'm confronted with something I've never seen before, is what I'm about to read going to help me or hinder me? So that's the level at which I tend to pitch things, so that everyone is aware. And sometimes having something visual can be really, really helpful in that situation to work through. And it also means, same as most of us, if we want to prove an element of expertise, if you can take something complicated and make it in its simplest form, then it shows your understanding, but also means that it is so much easier for people to understand if they haven't got your expertise and knowledge behind them. There has to be an element of fairness. People need to know what their roles and responsibilities are within the SOP. And they do need to be sort of fairly easy to understand and follow. So if you've got it that it's, a 10-page flow chart, then I think you've probably either got the wrong thing you're trying to do. It shouldn't be a SOP. It might need to be a policy, and you need to pick out aspects of a policy that becomes a SOP. That's how you're going to enact it. But it shouldn't be overly complicated. And sometimes it's a good idea to get somebody who has no healthcare background to read something that you've written, or to have a look at the flow chart that you've produced, just to see if it does make any sort of sense and they are joined up. Because sometimes we get embroiled in our own language and our own approach to how we say things and write things, and it doesn't make any sense to anyone else outside of our own brain. So that's what a good SOP should be providing for us. So the benefits of it are very similar to the benefits of having any good sort of procedure, guideline, standard in place. It gives people some accountability for the actions that they're taking in a department. And along with the accountability also is quite empowering. What we've looked at with some of the work that we've been doing in our local emergency department is actually empowering nurses that have got a huge amount of skill and knowledge, and actually having SOPs in place like this, the one that I'm going to come on and talk about in a little while, is the person that gets empowered is the triage nurse. We're giving them permission to practice within their skills. So without it in place, they're going to feel vulnerable. They're not going to feel that they can actually make decisions based on the knowledge and experience that they have. So a SOP is really helpful in those situations, because it does give somebody something, a little bit of sort of armor to take things forward and to change things, or to expedite care for patients, which is where you then get this consistency in what's happening. That would be the benefit of having a SOP, is everything is consistent. So if a patient turns up, 10 different patients, but with a similar problem of pain, or as the SOP I'm going to talk about has got post-operative problems, everyone will get treated the same, regardless of who's on triage or what problem they've attended with. As long as it fits within the SOP, the process will carry on regardless. I mean, it'd be nice to say that SOPs take away all errors and all problems, but we work in healthcare. There is no chance of anything ever happening that will take away all of our risk of error. We are all human. The patients that we see are human. So information is gets distorted and understanding doesn't happen and communication is miscommunicated. So there will always be, but actually having a well-written SOP for procedures, particularly where there's risk involved, can actually minimize things, can take out errors and variation and risk in the majority of patients that are going to be treated under that process. I think, you know, as an ex-senior nurse and now consultant nurse, having a good SOP does set an expectation of behaviour. We expect our nursing staff or our medical staff or our housekeepers or reception staff to behave in a certain way once it's actually covered off by a SOP. So that's where the empowering bit works well, but also does set standards for what you think is acceptable within your own department, how we want somebody to behave with their communication, because it should be clear within the SOP what that is in reference to, but also how that is received if you're discussing it with other specialities and what their roles and responsibilities are within there. So it should take out an awful lot of some of that human friction that sometimes happens during communication. So if you've written it well, it's been agreed, it's gone through processes, that's where it will start helping and benefiting patients, which ultimately is what we're all there to do. The downside, well, it can stop people thinking outside the box, but actually in a SOP, it would be something that's actually there to create that consistency. It shouldn't be something that is affecting creativity in there in the same way, but it can stop people thinking. I think all of us can fall into, particularly ones in a busy department where there's lots of pressures at different times, it's very easy to fall into processes of behaviours that follow this rule and that rule and the other, and then sometimes you don't actually think, oh, what is really going on here? Have I, looked at this patient with fresh eyes, or have I just immediately put them that they follow this procedure or this problem or this process? So it is easy if you've got too many things that are bound in all of our decision making, that you stop actually thinking about what is really going on there. It could be misinterpreted or interpreted in different ways, and that's always the danger, which is why simple, clear language is much easier to use there, so that there is less room for misinterpretation of what it means. And again, some of that sort of how you get a SOP enacted or being used in process, that actually comes when particularly if you're working with different specialities, that's where lots of that negotiation is needed to make sure that it can't get misinterpreted or interpreted by different people at different times in different ways. Review dates on everything come around far too quickly. I'm desperately trying to organise all our guidelines, and before I can get anything sorted, they're all going to need reviewing. So it's never ending. Evidence changes all the time, processes changes all the time. So it is quite difficult keeping on top of all of these processes in all our emergency departments. And again, some of those things are going to be governed by your organisation. Some organisations may be comfortable with a 3 to 5 year review of certain processes. Some of them expect brand new reviews every sort of 18 months to 2 years. So it's having a look at what your organisation wants. And boxing a bit clever sometimes with how you write things, that do they need to be reviewed, and who's going to review and what forms part of it. Is it a review to see if there's new evidence? But a SOP shouldn't really be influenced in quite the same way, because that isn't what it's about. Guidelines will be influenced more by new evidence coming out. But a SOP details how you should be doing something, and as most of us that have been nursing for a number of years, how you catheterize a patient has not changed greatly over the years at all. So lots of these things where you are having something overarching that tells you how to do a task, that shouldn't really be influenced too greatly as things change. So where do you start if you're going to write one? Well, ask for the template, and good luck with that. So, some departments run amok and have their own version of everything. Some directorates, divisions, whatever your organisational structure will have in place may be different at different levels. Some people have no templates. Some organisations are really organised when it comes to guidelines and policies and procedures, and have a corporate view on it and how it's all managed. So yeah, trying to dig out what happens in your own workplace, in your own organization, having a chat with whoever your quality and safety or similar sort of lead is. They should be your sort of go-to for anything like this. Or if you've got somebody who's leading on policies and procedures and guidelines within your department or directorate, they would be the ones to sort of start. And also finding out from them, you've got your template, you're going to write it up. So what you're going to do with it, how are you going to get it approved? What's your processes for that? Does it need to go to an operational meeting with directorate managers and lead nurses? Is it something that needs to go through a quality and safety review? Who's going to own it? Do you own it in the emergency department? Does it actually belong to another speciality? And are you just going to follow their SOP? Because they've imposed it on you. So it's having a look at who these things belong. So it's getting a bit of understanding of the organisation that you work in. Now that gets to be difficult if you are somebody at a more junior level, whereas actually the more senior you become, the more aware you are of these processes and how much easier it is to sort of navigate some of the challenges that come with it. Then you want to know how you're going to implement it. You know, does it just need to go on the intranet or on the internet or whatever your platform is for letting people know that you've got a new process? Does it go through your education team? Do they teach everyone all the new policies? So it's understanding what you're going to do, because if you're going to spend some time writing it, there's no point in it gathering, well, not just on the shelf anymore because everything's electronic, but you know, same principles. It doesn't need to be buried on a hard drive on a laptop somewhere. And it's things like, if you've been asked to do something or you think it's a good idea to do something, are you actually the right person to write it? Do you know what's going on in your organisation to be able to influence it? Do you know the procedure, the task that you're going to be writing the SOP on well enough to do that? Do you know all the other aspects of that so that you can actually influence it appropriately, and you've actually going to get the respect for when you're trying to have those conversations with people? So you may be the right person to write it, but you might actually need to co-opt somebody to go around and do all the conversations at different levels, depending on your organisation and where you sit within it. And do you know who to consult on it? Who you're going to talk to about it? If you're going to write it on your own, we can all sit and write all sorts of things if we want to. But actually, we might need to, particularly when we're thinking of the language that we're going to use, we might need to look at who's going to do it with us. And particularly if it's something that crosses over not just emergency medicine or emergency nursing, but into other specialities such as medicine or paediatrics, you might need to negotiate with somebody at your level working in an operational position who can actually give you their version of if you're going to write a SOP that's going to influence what they're doing. You make sure that all of that marries up and you've spoken to the right person there. So this is what I was asked to do. I was asked to write a SOP for post-operative patients attending the emergency department. So I followed the principles of find a template. We didn't have one. So Google is really, really helpful. I think I got a really nice template that was from Oxford University Hospitals. It's a fairly recent one. So it's out there. And actually, when I then started doing a bit of benchmarking of all the different templates that are out there for writing SOPs, and there are many, because it doesn't relate just to healthcare. It works in engineering, in offices, in IT, all sorts of places have SOPs as well. So it's having a look at what's going to work. So it might be worth finding something that follows a healthcare process. I did do some searching around in our guidelines and found things that were saved as guidelines but actually were SOPs. So I was able to use those templates to have a little look to see what was in the organisation. But be mindful of writing stuff like this. You might not have something in your organisation. You might need it. So you may be the one that's actually starting these things off. But otherwise, Google is always a good go-to. Most things, just be a bit sensible about what you've pulled off and what you're using.
Marianne, may I ask, did you check with your corporate secretary, your trust secretary? Okay, yeah, he's dead end there as well. But you know what? You've asked the question now, so now they've thought, hang on, people want templates, so they'll come up with one, which is good.
Well, what we're currently having, because in our emergency department we're doing a huge piece of work on transformation. I'm sure most emergency departments are doing very similar things to try and recover from the impact of COVID, and how we're going to try and get back to delivering emergency care again in some sort of form going forward. So we have started reviewing all of our guidelines, all of our pathways, all of our processes. So our first task was to go back to our corporate team, and there, you know, there isn't a formal process, there isn't anything set up. So they're waiting to see what we come up with, and I think that our guidelines, our pathways, processes will probably be something that gets adopted at a corporate level. So
Phone a friend time, isn't it? That's cheeky, that is.
It is a bit, but you know, if
corporate governance should have this covered off.
Well, I know there's a couple of organisations out there, a couple of English trusts that I'm aware of that actually have quite a good corporate approach to managing policies and guidelines and SOPs, because it makes sense, as I've discovered with doing the guidelines. Everybody writes all sorts of stuff all the time, right? It's not dated. I don't know who's approved it. I don't know who's going to review it. I don't know if it's been, you know, who's been part of doing any of it. So I was thinking of starting to do some prizes for people who actually put a date on it when it was written, on anything, a date when it needs to be reviewed, and actually just put their name on it, so I know who to go and find out what they did with it. But yeah, I might have to introduce prizes for it and work to.
I send stars.
Yeah, that's a good idea.
I just send an email with a gold star on it if somebody's done something really well.
Yeah.
And say, I've just found that, so that's a prize.
Yeah.
And our emergency department does FERF forms, favourable event reporting form. So they have a little form that if somebody's done something that someone really appreciates, they just write that down on a FERF and post it in the FERF box, and then it gets delivered to the person when they open the box once a month or so, and hand out the nice compliments just to cheer everybody up.
That's always good, isn't it?
Yeah, it's nice when somebody's taking the time to write something, because it takes them time to write it, doesn't it?
Yeah.
So, but anyway, that's a long way off templates. But
I resorted to Twitter when I found somebody who'd actually done one properly and had versions and ownership and all the other stuff. So I tweeted it to them and the rest of the organisation, just so that they're aware of it can be done, doing these things properly. I'm not sure whether or not he's used it as part of his appraisal feedback, but there was wide feedback.
Yeah, well, that's good, isn't it? Because then there's your revalidation stuff.
Yeah.
One in the bag.
Exactly. I think, you know, if from a nursing point of view, when we're looking at some of the things that we have to do now for our revalidation, when we're showing, you know, quality improvement, those types of things, actually writing a SOP and being involved in them is quite a nice thing to do, because it's stuff that, you know, it's how you're managing patients with certain things day in, day out. We're actually getting that bit right. It's quite a good bit of negotiation. So yeah, so for this post-operative one, we didn't have a previous version. There wasn't an agreement. We've got the sort of unwritten rule of failed discharge. If somebody reattends within 48 hours belonging to surgery or medicine or whoever has discharged them, then they go back to that speciality. But we needed something more for this SOP. So we didn't have anything to go on. So I had to start from scratch as to what I was writing. So the approvals process that we've got in place with us is I've written it. It's gone to our clinical directors for emergency medicine and for surgery, so that they've got a first sight of it. So I'm getting the right level engrossed in the beginning, and it's trying to make sure that you are trying to get the ear of the right people. Because firstly, once you start writing it and you're on your first draft of anything like this, but particularly with a SOP where it's going to be that task orientated, what you want to do is just make sure that you're not going to get blocks from people. There's no point going through a huge amount of work. miss the point on, or miss the target of where it needs to be aimed. So the idea is that I'm trying to get the more senior people some buy-in there, because they're going to be the ones that are going to win the hearts and minds of their own teams as it sort of works through and works down to the shop floor level. It's, for our organisation, we have a quality and safety group. So documentation like this would go through a quality and safety, and our new agreement is that that gets owned by whichever speciality is going to enact it. So this SOP that I'm writing, I think the debate at the moment is, would it belong to general surgery because it affects them most, but the decision making for it lies within emergency medicine, so should it lie with us? So that's going to be a bit of our debate as to who owns it, because otherwise you have to go through so many different levels of approval for any of these policies and things, and it can take a long time, which again, if you've got a short turnaround of review dates, and it can take you 3 to 6 months sometimes to get through different meetings. If you hit the wrong time of year, meetings overrun, all of that stuff happens. It can be a bit challenging. So whenever you're writing anything, just bear that in mind, particularly if you need something urgently. So I boxed clever with how we were going to get urgent SOPs into place while going through these processes. If we needed to do something as part of transformation or any of the other things in a more reactive way, that we could take things to our operational meetings that happen. We have 2 a week. And I'm sure most emergency departments have very regular operational meetings looking at problems and pressures. So if you needed something going through quickly, you can get things approved and in place, with actually then going through the more formal processes in background, just to make sure people are aware of it. But checking out what your local approvals process is part of your early work of figuring out how you're going to write this SOP. And how are you going to implement it? Well, one of the other things is, how do you tell people? Well, we've got Facebook groups, we use Twitter, everyone's got an email address, but not everybody likes to open an email, because it's very easy to say, oh, I don't know how to do it. I refuse to accept that from staff anymore. It's, you know, I would have accepted it back in the back in the day when we were all learning how to do this, but you know, it's not really an excuse anymore. But it is looking at different ways. How do you, and particularly in an emergency department, if you think of all the different policies, processes, standards, quality improvement projects, research, audit, everything that's going on all of the time. You've got nursing handovers that are very full of different focuses of different things that are happening all the time. It's very dynamic. All of the stuff that's happening around what really just goes on within the emergency department. Letting everyone know about things is very challenging, and you can tell people, but everyone forgets as well, because we're all human. So if you want something implemented, it might be worth having a look at actually who's going to actually be using this, who do you want to target, who's your key people for communication within your department. And all of us know, if you tell a few key people, we will all know who they are in our department. If you want somebody to know something widely, tell so and so and so and so, and then everybody will know by the end of the week. So it is boxing a bit clever, and that's where, when you are taking on these types of pieces of work, it's actually looking at the bigger picture bit of who's going to, you know, do some of the winning hearts and minds bit for you as well. So, you know, when I was looking at, am I going to do this? Do I know the organisation well enough to actually get this done? Well, I'm at a level that I do. I can get hold of the right people at the right level to get things through. But actually, if I was a band 5 staff nurse in the department, had been asked to do something like this, or a new band 6 as part of their development, I might not have the organisational nous at that time, because quite often when you're working clinically and you're very focused, and you may be asked to be part of something like this as a part of your development process, you won't necessarily know who the right managers are at different levels and things. But this is a good opportunity to get to see some of those broader things that influence the department and get you to understand the organisation a bit better, because you do get to feel a little bit cut off sometimes when you're on the shop floor and don't really understand all the bigger processes, and why, you know, we get mired in writing SOPs for post-operative patients. Did I know the subject well enough? Well, I do. I've worked as a surgical nurse practitioner as well as an emergency nurse practitioner, or an advanced nurse practitioner in emergency. departments, so I had a bit of an understanding of what the problem was, so I could write it in the right language. I had enough knowledge and background with this, so I could actually explain it to people in the right way. So if you are thinking of taking these things on, just make sure that you actually do have a bit of understanding and knowledge of the subject that you're going to be writing your SOP on. And was I the right person? Unfortunately, it seems to be yes, I was. So I can't get out of writing certain things now. When you get to certain management levels and responsibility levels. So I was the right person at that bit of time to do it. But actually, if I wasn't, I think it's okay to say I'm not the right person. I can help somebody, I can support somebody. And I think that's really key when you're looking at writing policies and you're looking at writing SOPs or guidelines or being part of any of those pieces of work. It's not just about whether or not you're learning or developing or being part of that process, but actually this is something that's got an impact on the work environment, and you do have to be the right person to be able to influence it properly. I've got colleagues that have had challenges in the past where they may be the right person, but the person who wrote it previously or who's involved still wants to be involved, even though they're no longer the right person. So you do get challenges when you're starting to write these types of pieces of work. And yes, I did know who to consult. So we've talked about, I need to, because this is going to influence from quite a high level, I need to start at that level to get this particular SOP through. But actually, if we're, as I was talking in the example, if we're talking about pain management and multidisciplinary approach, or how I was going to influence that, I might know who to consult some people, but it wouldn't be until I spoke to, say, pharmacy would I realise some of our stumbling blocks and who I need to be involved might be other people. So you might actually find as you go through the process that who you think you need to consult isn't actually who you've got involved in supporting it with you. So again, writing the SOP sometimes is easy, but actually all the other bits and pieces of housekeeping that go with it can sometimes be more challenging. So a general template, if you're going to write one, is that it should have a title page, and it should be sort of quite clear what it's relating to as the SOP. It should have the dates on it. As I've said, please, just put the dates that it was written. So I've got a version control on the one I'm writing currently, and that is dated. So you can, with the best will in the world, we save different versions of different things in different ways, and we lose it, and we remember things differently. So keep them dated. And once it's approved, make sure that date is on there, and whatever the date for review is. One of the things I'm trying to arrange with our guidelines and SOPs and all of these things is that we've got a process of actually alerting people when they start needing to be reviewed. So they get 6 months notice and then 3 months notice, and then they get strongly worded email to say sort this out because it's out of date. So you do need to sort of keep on top of those things, and as I say, from a SOP point of view, quite often you just need to review whether or not that process is still working, whether that procedure is still in place and still relevant or not. So it may well be when it comes to be reviewed, it's no longer required. Systems have changed, processes and procedures have changed, so it no longer is needed for use. You need to have documented on there as well your organisational approval as to which groups have approved this, have had sight of it and have made final approval and ownership of it. So those should be on your title page at the beginning. So it should have a title that's clear, the dates for it, and who in the organisation own it and have approved it. Then when you start getting into the meat of what should be in there, it should have a clear purpose. What is this standard operating procedure about? Why have you got it? You need to have an introduction that is going to give you some ideas, some context of what it's all about, what it relates to, why it's come about in background, if there's a reason why this has come into place now. So one that I've written has come out of a review of our processes. So I've got to justify why we've started doing something that we've never had done not had in place previously. Need to be clear of what the scope of it is about. Is who does it relate to? That from a staff, from a patient, from a procedure, what does it relate to? And so it's a bit like if you're looking at a piece of research or an audit or something, you want your inclusion and your exclusion. So what does it, who's it focused on, but who who doesn't it belong to, who isn't it referring to within there. So that needs to be quite clear on there as part of when you're working through the body of the thing. The definitions that you use there can be standard definitions, but they can also be definitions that are pertinent to the SOP that you're writing. So the definitions that I've used in the one when we go through it shortly are ones that are pertinent to the SOP that's been written. They're not standard definitions that are out there, because that isn't how it's going to work. It's not what's going to be relevant for it. So again, you do have some leeway, but your definitions do need to be clear, and you need to explain why you're using those definitions so that everybody understands. So when we were talking previously about things being open to misinterpretation, this is your time in your SOP of making sure that there is clarity of what you're talking about. The roles and responsibilities need to be quite clear as to who they relate to, and they're usually not to a person, it would be to a role. So I've talked in mine about the triage nurse or the streaming nurse or the consultant in charge of emergency department or the specialty doctor, because I can't talk about people because I don't know who's going to be using it on the day in, day out side of it, and people change and move on. So it is about a role that somebody has in the department and the responsibility that they have to enact this SOP within that role. So somebody may be a triage nurse one day, a streaming nurse another day, they may be the nurse in charge on a third day. So under this policy, they may have 3 different roles depending on what role they have, or lots of responsibilities depending on what role they have on that day. Under the specific process, that's where you need to think about your very fancy flow charts and how you're going to just sort of map out what this SOP refers to. If not, you need to be very clear in the language that if you've written it out purely in that way, depending on what you're writing, that people do understand that this is what the specific process associated with that is. And then having some references to support it. So again, it's looking, if you want to be selling this to other specialities, is making sure that the evidence that you're using to support the process that or procedure that you're putting in place is actually current, it's relevant, and it is something that they can see, particularly in the case of the one that I've written, is actually speaking to what is surgical standards rather than emergency medicine standards, because otherwise I'm not going to be able to get somebody from another speciality to understand why they need to behave in a certain way from an emergency medicine point of view if I'm using my standards, because they won't have the same meaning to a surgeon as the surgical standards of care may have. So it's having a look at what references you're using. And again, in some of the SOPs and guidelines and things I've written in the past, you tend to find some clinical conditions, some procedures and processes out there. There isn't an awful lot of new evidence. It may be something that's really historic, that we've always done it that way. And if it's still right and relevant, then it's reasonable. I mean, in academia, we all get taught, everything's got to be in the last 10 years, or, in the last 5 years, it'd be even better. But actually, the only research that's gone on in the last two years or so is COVID related. So there's not a lot of, lots of our evidence and references and things are actually lapsing a little bit. So it can be a bit challenging sometimes. So just have a think about what you've put in there to support your SOP. So I'm sure this has been covered off in previous talks about the fonts that you're going to use, and some organisations are really particular about what you use. I would suggest you don't go too relaxed and informal and, get a bit of the handwriting version. And I have submitted in my early academic days a whole assignment in Comic Sans, which was didn't go down very well. I did pass the module, but I think they were very kind to me. But yes, it is bearing in mind what you're writing in. It is a professional piece of work. It should be treated in that way. So the Calibri or the Arial I quite like. I tend to use that font for most of mine. Times New Roman is just painful on the eyes, I think. But you do need to remember it's got to be a consistent font all the way through. And it should be one of the more professional ones, shall we say. And again, this has already been reinforced in previous talks when you're looking at how you're going to write it. So you've picked the right professional version of font, but you want to get the sizes right, so you haven't got a mismatch of what's going on. If you look at the sort of bottom bit in Latin, it just looks messy. I mean, apart from the fact it's Latin anyway, it is just a messy thing to read. And actually, if you want somebody to take things seriously, in the same way we put on our uniforms and make ourselves look professional in what we're doing, that's what you want your piece of written work to look like. You want this to have some professionalism in how it looks. You don't want to look like it's just been cobbled together and it's got a coffee stain in the middle of it, because that's just not going to get anyone to take it seriously. So again, being consistent, you would expect to have, I tend to use bold for the headings as I'm going through, just because it's easy sometimes if you want somebody to look at things that are key within there. But again, whatever you've done is make sure it's consistent on the way through. If you haven't got a formal template in your organization for there, your text should usually be around sort of size 12. If you go anything smaller than that, if people are using this on electronic devices, it can actually get quite difficult to read, and then you end up sort of opening it up and squinting your eyes at it. And remember, we're trying to write something that is easy to read and understand for 3 o'clock in the morning with the most junior member of your team. So making it messy and complicated is not helpful to anyone. So this aspect of writing it is as important as the content. And formatting it, again, this is a standard approach and advice and guidance on what you should be doing. So it's generally black on white. You shouldn't have colour on there. I love an exclamation mark, but I don't use them outside of my emails or my texting. And, you know, no emojis or any other exciting bits of gadgets that we can do. But think about, you don't necessarily want to have, as an academic piece of work quite often is all double spaced and spread out, whereas you need to make it sort of compact enough that it doesn't look like it's a 15-page document when actually it could be a 10. But you need to have it that actually flows nicely, that it looks well. You do need to check your spelling. I've been caught out quite a lot recently. For some reason, our Word programs keep defaulting to the US spellings of everything. So you get Z's in places, and it does mess about pediatrician. If as a pediatric nurse, I tend to get caught out on that one with the spelling on there. They drop off the A, and then it's not until after the fact you realise it's not the right spelling. So just be careful. We now all use computers for all of what we're doing. Not like the good old days where you may have had to write it down and you can blame misspelling then on poor recall. We've got good reason to actually get it right, so make sure that you have. And again, it's you're not to get excited. There shouldn't be exclamation marks about the place. So remember that your grammar is succinct, that you have got your commas in the right place, that you are actually ending sentences that make sense. And it shouldn't be, I think you should be doing this job, and I think this will be a really good idea for everyone to do this in work with patients who come in with pain. It is a professional document. It should be written in that way, with as much sort of neutrality as possible. So that's a lot of bits and pieces we've got through on there so far. I'm not sure if we've got any questions that we want to cover off at the moment, or maybe it's coming up to time to have a little break. Okay, so I'm hoping you've all enjoyed having a little break, and on we go. So applying all of this to a SOP. Let me see if I can just move us out of the way a little bit more. So I was asked to write a SOP on how we're going to manage post-operative patients who have had a surgical procedure and then they turn up in the emergency department, and what was the rules around it. We'd had some issues with patients. Who's going to take ownership of them? What's the right thing to safely manage them? So I'd got asked, how are we going to solve this problem? We need to put a SOP in place. We need to have an agreement. What are you going to do? So this is the SOP that I came up with, and it makes it a bit more sensible to understand and figure out how you're going to write it if we're talking about something that's real. So as I talked about, you need to have a purpose of it. So imagine I've got my title, care of the emergency of patients who attend the emergency department within 30 days of a surgical procedure. That's going to be my title of sorts on there. I've had it approved, so my front page has got its dates of approval on it, its dates of review, who owns it, and who in the organisation has actually said, yeah, this is what we're going to do with every surgical patient that comes into the emergency department. So I've put the purpose on there to try and be as clear and precise as possible, so that so you can't often make it short, punchy sentences, which we all quite like, things are nice and snappy about the place, but actually there has to be clarity of what you've done. So the purpose of this was actually to make it clear who's got responsibility for safely managing patients who come back to the emergency department with a clinical problem associated with their surgical procedure within 30 days of that procedure. So it isn't going to be about patients that come back with a stubbed toe after they've had, a laparotomy. It is going to be about patients that may come back in with a wound infection after a laparotomy. So it's making it clear as to what it's about. So whatever your SOP is going to be, so going back to previous examples when we talked about pain management or pain assessment, that SOP would be, the purpose of it would be to detail the responsibilities in the process for assessing pain for patients attending the emergency department with a limb injury, for example. So you may just have a SOP that focuses on a specific aspect of a patient's care process or journey. But this is the one that I've written about the emergency unit and our surgical patients coming back. So giving it context, that's what the introduction's about. So I know it's a bit wordy on this slide, but I've just done a cut and paste of the beginning bit of the introduction that I used there, and just to demonstrate how to use some of that language, how I'm going to influence. So I've got to get the surgeons across their specialities, so it's not general surgery, it's ENT, it's gynae, it's ophthalmology, it's anybody who does a surgical procedure, to be bought into enacting this SOP and working within it as well. So I had to use a language that was actually going to speak to them within there. So it's looking at research and evidence about reattendance within 30 days of surgical procedures. So those are the references that I've used there. I've used current references on there, and it's showing why it's a problem. So it's actually recognizing that actually within that 30-day period, those patients are seen as risky, and most of them actually require admission. So they're not coming in with a stub toe, they're coming in with a problem that actually needs further, surgical intervention. So it's speaking to the surgeons about what the problems are there, because it's very easy for people to dismiss issues and say, well, your emergency department should be able to sort everything out, and it's quite simple to manage that problem. Why aren't you doing it? Whereas actually, it isn't simple for an emergency nurse or physician to be managing a problem that actually was part of a surgical process or procedure. So it is making sure. That's what the introduction is doing, is setting that scene in the context of why we've got that SOP in place, and who it's going to be influencing or affecting, and how that's going to work. So I've talked about in this one our normal processes, whereas actually we would triage them. An EU clinician would look at them within our normal triage approach of clinical priority. We'd do some acute clinical care, and then we'd refer on to the surgical speciality. But actually there's no timeframes for that in place. There's no urgency. There's no priority given from a surgical point of view to some of these patients that are coming in and not recognizing actually the risks that this group of patients hold for within an emergency department. And actually we did have a serious case where somebody had presented outside the 48 hours, which is our general rule of failed discharge, had come to the emergency department with a recognised complication of following a surgical intervention, and was stable, but we all know the pressures at the moment. We've got huge amounts of delays and risks within all our departments. So actually you want to be able to tease out the patients where you can actually get the right people to see them sooner rather than later, which is what's the purpose of this SOP, is to get the surgical team to come and make those decisions and assessments for that patient group, because they're the ones that carry that expertise. So it's making sure that they recognise that their role in there is valuable. And again, that's where the language is. It's about that their standards are about this 30-day post-operative period is a red flag. Is it within their good surgical practice guidelines? So those are the references that I've used there, and that's the language I've used. So when you're writing the SOP and you're writing that introduction, think about who you're aiming this for. If you're writing this for the nursing staff to be following, then you write this in the way that the nursing staff are going to understand and speak. If you're writing it for the doctors, then you write it in a way that they're going to understand. But you know, the SOP that I've written here is very much focused on surgery, so I have to write it in a way that the surgeon's going to relate to. There's no point in me putting in what is our standards and great details of triage and issues within emergency medicine for surgical patients. I need to talk to them from their own Royal College, because they can't really argue with something that is their own standard when we're trying to pull it into place. So that's where boxing a little bit clever and thinking about how you're going to influence and how you're going to win the hearts and minds of those that you want them to be working with you under this SOP is going to work out. So that was the introduction, that very much giving that context of why you've got it, what it's all about, but using the language of those that are going to read it, that you want them to be using it.
It's quite subtle, that, isn't it? It's not a massive difference, but putting the fact that it's all surgical specialties and it's about the previous 30 days, and then that statistic about at least half of them are going to need to be admitted, and then you finish on the punchline of the Royal College of Surgeons says it's a red flag if they come back in 30 days. You know, so you start them there, and then you finish them there, and but it's quite subtle. There's not a huge effort on banging it into the surgeons at all. It's
no, and it is, you know, and these are skills that you learn over time. You know, this is, if I was going to have a conversation with them face to face, that's where I would be starting from. So again, it's using your written language in that similar sort of way, but you know, it's remembering people have got no time for reading long wordy documents that are very convoluted. I could have written, you know, prose on all the issues that we have in the emergency department with all of these patients coming back and poor patient stories, and they are all there and they are all valid, but it's not going to get a SOP approved or enacted because it's overly complicated.
It doesn't pass your 3 a.m. test, does it?
No, it doesn't.
It doesn't work at 3 a.m, so no. It doesn't work.
Yeah, you've got to keep it. And again, you know, I found, you know, from experience, it speaks the language of the people that you really want to win. So the emergency department, like, it's a no-brainer for us. They need to go back to surgery. So I don't have to win hearts and minds in emergency medicine. I don't have to say to them, you know, we need to be sending them. They're not going to say, no, they're our patients, we'll look after them. They're like, we don't know what to do with these patients. They've got a surgical problem that the surgeons created because they did an operation, and they need to go back. So it's really thinking that through when you're writing it. And again, you know, if I was writing this from a pain point of view and I was having to negotiate with the pharmacy or the pain team or the anaesthetist, then it's looking at getting their standards and their information in there succinctly so that you get them to realize, oh, well, that's the language I use, that's my role within there. But keeping it, you know, punchy as much as you can. Mm-hmm. So again, you know, we've talked about an introduction, giving us our context of why we're doing it. We've talked about then the scope comes next. Who's in and who's out? Who does this relate to? So this is exactly what I've written as our scope for this SOP, and it's all the patients that have had a surgical patient under the care of a named surgical consultant. So there again, it's using that language so that there isn't a get out clause for anyone, because anybody who has surgery in secondary care has a named surgical consultant. and they have a team that work, but there is a named consultant overarching all those procedures. So it doesn't matter which speciality, there will be a consultant in charge of them. And what we're saying in the emergency department is that what we're going to do is do our normal assessment. We're going to figure out that actually, you know, at triage, our nurses can figure out, or our streaming nurse who often supports that process when there needs to be referral on to specialities directly, they can make that assessment that this is a problem, a complaint that the patient is reattended with that is related to that surgical intervention that they've had. So we're talking of things like, you know, wound dehiscence, infection, pain at the wound site, you know, pain particularly out of proportion to the procedure or the time that they've presented that would be surgically related. So if, you know, an abdominal pain following abdominal surgery would, you know, the best person to decide whether that's a problem or not is the surgeon. And a general surgeon rather than an ENT surgeon, of course. So it's recognizing who they should go to as part of all of that. And it's then putting some targets in them for the surgical teams of what's reasonable. And it's again highlighting again, the Royal College of Surgeons has said this is a risk. So we're going to say in emergency medicine, we manage our risky patients within timeframes in the world that works smoothly and very easily, and everyone gets seen and sorted within 15 minutes, and we don't have 25-hour waits on ambulances. But you know, it is putting some times in there that actually are appropriate. So if you have somebody who attends in a collapsed state following a surgical procedure, we don't want to delay in that surgical team bringing their expertise to that patient's assessment. So it is reasonable to put in our acute timeframes there, and again putting it in later. So whatever you're using in your SOP, start putting some clarity in as what the thresholds are. So again, if there are incidences that fall outside how the SOP is being enacted, then you've got some measures to see where the fall down is, or actually to measure when things work very well. What it doesn't include in here, and that's what you need to be quite clear as well when you're writing it, is who it doesn't relate to. So when we go on to the definitions, they'll put some more clarity, or I've put some more clarity in there as what sort of things the this SOP doesn't relate to within, and I've used the sort of stubbed toe example as a thing, because patients do have a surgical procedure and may fall over and break an ankle. That isn't related to the surgical procedure, and I wouldn't refer them back to a general surgeon when they've actually got a fractured ankle and they might need to see an orthopod instead. So it is making sure that it is incumbent on us then in the emergency department that we're referring on the right patients. And that's where, when we're enacting it, is making sure people are aware of what their roles is and what it relates to properly, rather than a blanket, well, they had surgery, you know, 28 days ago, so every problem they may attend the emergency department with has to go back to their surgical team. And we can't act in that way, and this SOP makes it clear that that isn't going to be acceptable for us to do in the emergency department. So it's that, who's in and who's out, and be clear on it. And again, the definitions that I've used in this SOP aren't particularly standard definitions out there. So I've taken a bit of artistic license in so much as I've looked at, firstly I looked at, were there definitions from the Royal College of Surgeons about what a surgical procedure was. That was the term that I was using in this SOP. So again, it's being consistent in your writing, so you're not going to change it to surgery or a surgical process or change or operation. It's if you're going to use one term, use the same term all the way through, so you've got that consistency in your writing in there. So when I would say surgical procedure, I'm looking at anything that's sort of usually knife to skin type approach, but then, you know, we've got laparoscopies and endoscopies and various sort of scopies and things where there isn't a knife involved. So it's a surgical intervention that's been carried out, and I've kept it within secondary care, because that's our high risk patient group there, because some surgical procedures are carried out by GPs in primary care, and that's not the group that we're relating to this. This is very much our secondary care colleagues that are carrying out surgery. So again, it's being clear as to who they refer to, and again, the fact that they belong to a consultant surgeon or a member of their team. So it's within that whole sort of team ethos that they have in surgery there. The other definition I've put in here, a post-operative complaint. So I've kept it as complaint rather than condition, because in emergency departments, we know patients generally come in with a complaint. They have pain, they have shortness of breath, they have leg ache. So they come in with a complaint rather than a formal diagnosis or condition at that point in time. So it's easier using that terminology there rather than saying something that's got a diagnostic element to it, because the idea of having this is that we're not going to make that diagnosis in the emergency department. That's for the surgical team to be making. But it's making it clear that actually these are the things that we would see as being problems related to having that surgical procedure. But actually having a chest infection as part of your post-operative journey isn't really something that we necessarily need to send back to the surgical team that did the procedure. It may be that they'll be consulted on there and made aware of their patient coming back in, but actually might find the respiratory team or the general medical team are better placed to manage that patient, and you wouldn't want to be sending them back to the wrong area either. DVTs, again, the surgical team might need to know that they've attended, their patient has attended with a post-operative complication or problem that's part of the general list of things that can happen, but not necessarily something related directly to the surgery, because it's the problems that we want this SOP to cover are the ones related to the surgery, because that's where the risk lies. Chest infections, DVTs, we've got processes in place that mitigate against that in a post-operative period, and we've also got established guidelines and pathways to manage them because they're standard presentations. We see that in patients regardless of whether or not they've had surgery. So this was trying within the definitions to put that clarity. So thinking when you're writing your definitions, what does it really mean? What is your language that you use? And making sure that that's consistent throughout the SOP. And then when you're having those conversations, when you're implementing it or when you're getting it approved, that you've had that consistency in your language throughout the written piece, but also what you're having when you're presenting it, when you're trying to get people to agree and approve it as well. I tend to find when I'm doing pieces of written work like this, I'm a bit like most people, we can all be a bit dreamers and airy-fairy, and we can go off on different tangents and get a little bit artistic license. So sometimes it's quite handy to write down what is your specific things that you want to be consistent on. So, you know, I might write surgical procedure and post it on the side of my laptop so that when I'm writing anything, I'm remembering to use the right term all the way through, so that you're keeping that clarity. And again, then it's looking, so we've given the purpose, we've given the scope, we've put some context in there, we're starting to put some definitions in there. So everyone's starting to build on there now as to what is all of this about, who's going to do what. And then it's looking at who's the key people that are going to enact this, who does this relate to from actually role and responsibility in the workplace. So the triage nurse has the first key responsibility under the SOP that I've written here. And what I've written there is about their responsibility. It's reminding them that the other processes that we have in the department that they can use to support them in their decision making, because it may be they've got 10 patients that have just booked in at the same time that need triage. So actually they've seen that this patient needs to be referred back to the surgeons directly under this SOP, but they may not be the right person to do at that point in time. So they need to know who else they can call on to support them. So it may be whoever's our streaming nurse of the day, who's somebody who's given authority to work fairly autonomously under our nurse-led pathways, and that's what this SOP would fall under for them there. Or looking at any of our sort of rapid assessment teams that can then expedite that referral for them, so that we've got a SOP that can be used to expedite the care of certain patient groups, but doesn't then impact. We've got systems in place that isn't going to impact on other patients' assessment and care, because triage is where we carry our most risk, isn't it? So then again, the other person that's involved is the streaming nurse. So I've detailed what their role and responsibility is within there. And it may be that then they would be the ones that are actually doing the next level of actually putting in a cannula, taking some bloods, giving some analgesia, starting some treatment. Those types of things would be their role. That isn't what we would be expecting our triage nurse to do. So our triage nurse is very much going to identify this patient within the group of patients that they've got that this SOP relates to. The streaming nurse has got their roles and responsibility. I've made it clear in here that actually the senior EU clinician, who in our department generally our emergency consultant in charge, is called the EPIC. So I think that's a term that seems to be getting adopted about the place.
Ours are called that as well. I'm sure they just like being called epics.
I think they've made it up on purpose.
I think, I wonder if is it American, because the P must be for physician, mustn't it? Is it emergency physician in charge? So that's not a very British term, is it? So
no. It makes me laugh. I'm a bit long in the tooth to take it entirely seriously.
Who's the epic? Oh, yeah, right.
Who's epic today?
Here comes the ego.
I couldn't possibly comment. But yeah, it's whoever is our senior clinician. But we haven't always got an epic. There isn't really an epic by night, because it's our trauma team leader who may not be that. We could have a registrar. So it's our senior clinician, and we've got senior clinicians in different areas. So I didn't want to say it was the epic in this. I quite deliberately haven't used that.
Oh, it spoils sport.
I know. But it would mean if we haven't got an epic, then I haven't got anyone to do it. So
no, you're right. It's really important that you've thought that through.
Yeah.
And you've deliberately chosen not to use a term that isn't there reliably 24 hours a day.
Exactly. So
because it doesn't work at 3 a.m. otherwise.
No, it doesn't. Because then they think, well, who do I phone? I'll wait till 7 o'clock in the morning when the epic turns up. And that's the issue with it, isn't it? It is really thinking it through. The language is so important when you're writing pieces of procedure and process like this, of actually getting it right. So don't rush them. She says sometimes knock them out quite quickly, but that becomes a bit of a dark art after a while, being able to get these things right.
But once you've learned that, the next time you've got to do one, you go, I did this last time, so actually the next time you do just go senior clinician.
Yeah.
And
you get to know over time, it is a practiced skill, and to be able to write these things properly and do them well have got such an impact on the department of actually making things work and work well. I mean, this is brilliant for a triage nurse that's there. They've only got to sort of pull it off the shelf and say, well, actually, it is my role to identify these patients. I've identified this patient has had surgery. They've reattended with abdominal pain or what looks like an abscess associated with their surgery. You, Mr. Surgeon, it is your job to come and see them. And you've got 60 minutes to come down because they're stable. Or they look really, really sick. I want you down here in 15 minutes, otherwise I'm escalating to your consultant. It is really empowering to have a SOP that supports, and particularly for nurses, I think all of us feel so much more secure when we are sort of challenging professionals that are seen more senior sometimes, particularly when you're talking to speciality groups that are quite often known to have quite a manner about them that can be a little bit challenging. So if we've actually got something written that supports the nurse in that role, it makes it much easier for you to just feel like, no, I am doing the right thing to advocate for my patient, that this, because it's written in black and white, that's what I should
just
be
reduce
doing.
That authority gradient back from the steep to something a little bit shallower. Just bring it down a little bit so that it saves a lot of mistakes as well once you've got it kind of down and under control a bit.
So yeah, this is why I've been sort of quite explicit on there, and I think it's always good with the roles and responsibilities to be clear who's got what. And again, it's around the title of the role, not the person who's going to be doing it. So I've put for here the surgical speciality team. So it could be anybody within that team that they choose to nominate. Each team works slightly differently. Some of our speciality teams, the registrar isn't always on site, but there's a junior doctor, but you might want to tell the registrar first, and he can get his junior to come, or she can get his junior to come and see the patient. But so it is about the team. It's for them, it should be the whole team need to be taking that responsibility for coming and making that judgment. And again, I've made it explicit in here that if they've assessed the patient and they've decided as a surgical speciality that what the patient has presented with is not related to their surgical procedure, then they have to refer the patient back onto the appropriate team. It's not back to emergency medicine. So
now that is a dark art. How did you manage to get agreement on that? Because most teams will eventually willingly come and review a patient in an emergency department.
Yeah.
But usually, if they think it's not me, then they go, I've checked the patient and it's not me.
Yeah.
They will not do that next referral. No. How did you crack that one?
I've got it written. The clinical director for surgery at the moment thinks it's a good piece of work. He has no problem with it. He's sending it out to his colleagues.
He didn't review it, did he?
It's written there.
Well done, though. Well done.
So yeah, we'll see how many people read it, because they're not junior doctors at 3 o'clock in the morning.
No,
and so as senior clinicians, they quite often don't read everything that comes across their desk. They'll just skim read something, not go into the detail. And once it's been approved, it's been approved. I'm very sorry, but there we go. But
you did approve it.
Yeah.
You assured me there was nothing you needed changed.
Exactly.
Here's your email.
So that's what I'm hoping I can get away with. I'll let you know.
I think that, but it's really good that you thought of that, because that is a problem that would otherwise have come up. And if you've got it covered off and blocked off, then that problem can't arise.
Yeah.
Or if it does, you've got the answer. No, your clinical directors are agreed to this, or your chief of service, or whatever you call them in your organization. No, they've agreed. That's, oh, really? I didn't do that in my last place. No, well, you do here.
And that's a really key important bit of when you're looking at a SOP is what are all the processes within it? How is that all going to work? And where are you going to go? Because I think one of our biggest problems often ends up being is that patient ping pong in the emergency department. So
and it's awful, isn't it? It's awful for the patient, awful for the staff.
Yeah, and it
just feel embarrassed for them, for the whole situation, really.
Which is why I was quite explicit on this, that actually they are a surgical team. They are a team with medical knowledge and ability. If they've made an assessment that this is something that does not belong within their gift to fix or sort, then there are other specialities that they can refer to, but you can't refer to the emergency department because we don't take referrals from speciality teams.
Oh, that's a good line. With the emergency team, we don't take referrals from specialities.
No.
Oh, very good. I like that line.
Yeah. It's language. I think
language. It's getting the right language.
And that's what doing stuff like this is really key. And taking the time to learn how to do these things well are really helpful in getting your skill set for being able to articulate what you want somebody to do properly. So we've got that. So I've put that in there as our roles and responsibilities in there. And as I've said, I've not, in the last bit, you can see in the sentence, I'm not going into detail in this SOP as to how to bleep someone, because those will change from time to time. We've got a new process coming in with our same-day emergency or surgical same-day emergency care process and things. So we're now using Consultant Connect to get a hold of the surgeons. But that isn't all the surgical teams at the moment. So there's no point in me putting the detail of something that is a day-to-day process within this SOP, because that isn't going to make any difference. We just need to know who's got what roles and responsibilities within there. Because the other thing, you'll either need a separate SOP, which it shouldn't do because it's part of normal routine work. But those things change too quickly, and you want something that's going to stand the test of time for at least sort of 2 or 3 years of saying, this is what we're going to do with this group of patients. These are the instructions for managing them as they come into the emergency department. So again, it's enough detail for it to be usable, but don't go into so much detail that it then is unworkable every time something changes, which could be every 6 months or so, or 6 minutes sometimes in the emergency department. And then what does it look like? So I said with the procedure, what's it going to look like? So within, after you've got all your sort of different processes, you've put all your words around it, you know, I love a good flow chart or a process map. So you can use things like Smart Art, and if you do, our transformation lead will just despair at something that is, you know, hurts her eyes. So she's converted me onto a different platform using Lucid charts, and there are other platforms available. I'm not plugging one over the other. This is ones that I use, and it's taken me a little bit because, you know, again, old dog, new tricks. It's how to work things out. But this is the process, the procedure for this SOP here. It's a bit bright there now, but you can see I've put in there in details as the triage nurse roles, any of the red flag issues within there that need to be managed as to whether or not this is a patient that needs urgent care, or if this is a patient that actually can wait for 60 minutes sort of care. So we've got our green yeses and our red no's. So red, you know, has got other aspects to it, but it's quite clear for somebody to have a look through at 3 o'clock in the morning. What am I going to do? Well, they've had a surgical procedure. We've got observations, we know they're stable, and we've given them some painkillers, because that's really good clinical care to actually give somebody some painkillers. They're not shocked. They haven't got bleeding, you know, bleeding out on the floor. They're not got an airway compromise, because remember, lots of the surgery may be related to ENT. They're not in a collapsed state, and they're not in severe pain. So if you've got any of those, you're going to want your EU senior involved. And again, it doesn't have to be the epic, whoever is most senior in the area that you are. You're going to consider transferring them to a safer area such as resus. You're going to consider then the IV access, cross-matching, analgesia, and you're going to escalate quickly to that surgical speciality team for them to come down within that 15 minutes. If they haven't got any of those problems, then it's reasonable you're directed there to contact the surgical speciality with a 60-minute target for them to come in. And if you think none of it is related to there, then they need, again, it's reinforced on there, the surgical team needs to refer to the appropriate speciality or discharge the patient. That patient doesn't come back into the emergency department system. So this is your 3 o'clock in the morning sort of bit of what am I then going to do? And these are, you know, it's quite a nice way to actually show this is what's happening on this SOP. These are the roles and responsibilities when they're enacted. It's a very sort of quick way of following it all through. And I love a flow chart. I think it really helps figure things out as to who's going to do what, where and when. And I think it shows sometimes as well, it's a much easier way to demonstrate what you should be doing. I'm quite visual in a lot of what I do. So something like this works very well for me. And I think in emergency medicine, most of us love a little flow chart. Everywhere's got a little flow chart.
Everybody goes back to the flow chart, don't they?
Yeah.
You'd like to think they read the rest of it, but the truth is they probably just look at the flow chart.
Yeah. And that's the bit. It's got to have the right amount of information. And again, this needs to be consistent. And it's always good to get things double checked by somebody who doesn't really understand the process, so that they have looked through to make sure that it makes sense, that your yeses and your nos and they flow to the right way. So you don't want to have, you know, I don't want my yeses coming off the red part of it, because then that crosses over and it doesn't look right. And you know, and our transformation lead will tell me off because the boxes are slightly different sizes. So there are consistency issues within these things. But again, it's finding something that's going to work for you, so that this SOP can be used, it can be operationalized, and it's easy to follow without people having to get, you know, textbooks out to understand what you've written and what's going on. So again, the references to support it. So in the opening gambit, when I was looking at the introduction, I've made sure that the references I used specifically for this SOP were related to surgery, they were related to surgical risk, and they were things that are going to be up to date and relevant, that the surgical team that I want to use this policy are going to relate to. If I was going to do this SOP for looking at pain management, or if I was going to look at it for any other sort of processes or procedures that we were going to say that this needed to have in place, then you need to have a look at what's going to support that properly for you and make sure that they're current and they're relevant. Again, you know, some organisations have a particular approach to referencing in there. We didn't have one specifically in ours, so I've just put the references in because it's Harvard referencing is what I'm most used to. But again, it does look does actually, you know, when we think about that formatting, when we were talking about having the same font and how it's all laid out, some of that professional bit of having it referenced in there appropriately to just support, to say, actually, I didn't just make this up because I felt like it. There is actually good reason why this is a risk, this is a process, that's why we've got this SOP in place to support it. There's going to be some SOPs where that isn't relevant. We've got one in particular for how we admit patients to our clinical decision unit. There isn't really a great deal of evidence that may or may not support the process that we've got, because that SOP is literally, this is who you go to, this is what you do, these are the forms, and it's very much that tick list on there. But for something like the one for the surgical patients, actually having some good evidence and references can be really helpful to make it a bit more powerful and put a bit more weight behind it. And then where am I coming up to next? Who should approve it? Well, again, it's who's going to give the nod on this one. So again, I was asked to do this by the clinical director. So I already started from a point of somebody who wanted this in place. So it's our clinical director, following meetings that they had with wider teams that were involved in a particular case where actually there hadn't been a good outcome for a patient, and we needed to be a bit smarter about how we were going to manage our post-operative patients. I've already got something that, you know, the door is open, it's a little bit ajar there, and as to who's going to approve it. But actually, we all know, you know, without any disrespect to surgeons, they can be quite a challenging group to get on board with things, to get them to approve things. So again, that's where it's looking at who's going to own it. So where does this risk lie? Well, this risk lies within the emergency department. So it's probably ours to own, even though we want the surgeons to do it. But the risk of them not doing it lies with us. It doesn't lie within their footprint. It doesn't lie really within their processes until they've accepted that patient. And
does
again,
it affect their morbidity and mortality figures?
It would.
As an individual, I mean, I appreciate the cardiothoracic surgeons are the ones that really go for the personalised data, but some of the others do as well, don't they? Would
well, they're
that
all expected
30-day problem affect their own personal figures?
Yeah, and it would do, but I'm not sure always. Will our data be pulling it through properly? You know, do they come out in their figures in the same way? You know, I'm not entirely sure of their processes. It should do. But actually, if it's something then that gets solved in the emergency department that, you know, never gets referred on to surgeons because they won't take the referral from us, would that then flag up in their stats? Would that become something that's known? So again, it'd be interesting if I get some of the conversations and make them out of it, because it should be part of
it should come into their M&M meetings. That, you know, of the 30 patients that we did a total HIP on, actually 20 of them tipped back up in the emergency department 5 hours later, you know, 5 hours after discharge. Now, that many of them, it wasn't a discharge problem, it was a surgical problem. Total hips is not a good choice, actually, because there's always lots of other things going on. I don't know, tonsillectomies. You know, if 2/3 of them tip up back in the emergency department within a week, there's a problem with your operating. There isn't a problem with the emergency department or with the discharge.
And that's why using their standards in this, about it's a 30-day standard for them, because I had similar conversations with our acute physicians, and the Royal College of Physicians seem to have a 28-day limit on their standards, because I was, oh, well, why have you got 28? Because the surgeons are everywhere in all their documents talk about 30, which is why I've put it in there. So again, it's, you know, it's what language of who you want them to be working this through with is going to work best for you.
Is that a 4 weeks versus a month?
Probably.
Do you think?
Probably. You know, and they've split the difference with 30 days instead of 29 or 31. So, you know, something random.
Whatever. Good to know the difference, though. If you're talking to physicians, it's 28 days. If you're talking to surgeons, it's 30. Okay, I can do that.
Yeah. We're very different beasts, I think, in nursing and stuff like that. It's but yeah, they've got arbitrary things on it. So again, if I'm getting it authorized, I need to have the surgical seniors on board with it. So trying to start at the top and working down is the best approach then, rather than start, you know, blanket send it all out to all the surgical consultants and say, this is what we've written, what do you think? I mean, that's just going to create a whole load of hoo-ha and fill up my inbox, which, you know, nobody needs that. So again, it's looking at, when you've written a SOP, how is this going to work within your organization? Is it something that's just departmental? Is it just about, you know, this is how we're going to do our pain assessment and this is how we're going to give our PGDs out? So that is within our gift in our department, would stay very much within that bubble. Anything that then starts looking outside, it's who and where you're going to go. So this needs to go to the surgical team, but I know they can be challenging characters. So you start at the top, you win your hearts and minds at the ones that's going to say, well, actually, the buck stops with me because I'm the clinical director or chief of staff or whatever. And I think this is the right thing to do because I know the different risks in there. And then that has to filter down, and it becomes their responsibility a little bit for making sure that there's compliance with it from theirs. But again, that's where within the organization, you may be the one that's written the SOP and knows it all really well, but you might not carry with it the level within the organization that means that you can push through the authorization. So again, it's looking at who can be your allies for doing these pieces of work, and how do you get them round the houses? And sometimes, you know, some of the people that you need to speak to are not always the ones that you think of, and surgical nurse practitioners can actually be quite influential with the surgeons. So you may want some of your nursing colleagues to be sort of coming at this problem from a slightly different angle if you want to win hearts and minds in a different way. So again, it's looking at who's going to approve it, and I'll let you know. I'll drop you an email once I've got it all through all the.
How many friends have you got amongst the surgical nurses?
I've got a few actually.
Chat up your mates.
Yeah, some of them owe me some favours as well.
It'd make their life easier though, wouldn't it?
Well,
because,
it's clarity.
You know, stable patient,
yeah.
Straight up.
Yeah.
It's not so, I mean, acutely unwell, well, that's just the way life is. Acutely unwell, you've got to come, you've got to come to us. But, you know, you could shift a stable patient up, couldn't you, quite easily, and have that agreement with the surgical areas.
And there's a growing numbers of surgical nurse, advanced nurse practitioners managing, and you know, I think they're ideally placed, and that's where I think nurses writing these types of processes and then using our colleagues to work with us to actually get things moving, and we generally know how to smooth the wheels of things to get patients the right care at the right place by the right person at the right time. So training is there now. Most of the time with SOPs, there isn't really an awful lot of training related to them. Most of them are processes or procedures that we've already got, but actually nobody's set the standard, nobody's put any clarity in there. You know, we have these patients turning up in the emergency department already. We still provide them with care. It's not, we recognize that actually we're not always the right people for seeing them, so we want the surgeons to see them and to take some ownership on them. But actually, we don't need to be trained to do that. We just need to have a SOP in place that says this is what you're allowed to do. Now, it may be that some of the triage nurses may need not necessarily training on what the SOP is, but actually somebody to go through it, make sure that they actually feel confident and assertive enough to actually enact it. If not, where are their support mechanisms? Is there something in development that we need to do as part of our training within the department? So those nurses that do triage or streaming are actually confident enough to sort of take on the challenge. Or, you know, do we need to give people improved communication skills so that they can comfortably do this without there being any issue? Or not, but usually a SOP doesn't or shouldn't require specific training as part of it. Sometimes if you've got new guidelines, they've got new equipment and bits and pieces, then yes. Or if you had a new SOP in that was related to a particular procedure that had kits or drugs or things that people would be unfamiliar with, then yes, there would be a training element. But in general, the SOP is just about organising and setting a standard procedure in place and making that clear. So it's not usually the training there. And you don't usually do an audit of SOPs in the same sort of way. It's not the same as if you're adhering to a guideline or a standard. So if you put things in place that say actually all of our patients should have pain assessment at triage and this is our pain ladder and everyone should have that. Well, those are sort of standard auditable type things, but a SOP generally falls outside of that. So there isn't usually a specific process of auditing compliance with a SOP, but actually once you have an incident that may be related to a SOP that's in place, then you may look back at sort of compliance on that as part of, you know, checking that it works on there. But there isn't usually a formal sort of compliance process within there. It's about having something that means that you can do what is your normal job well to a consistent standard. So there we go. So I'm hoping you now have a bit of a better understanding of what a SOP is, what is the function and the purpose of it, why they're really good to have in your department, and how to write a really good one. So don't forget about, you know, learning language, you know, writing well, being articulate, being consistent, how you're then going to get it improved and how you're going to introduce it, and what would happen if you didn't have one. You know, currently, if we haven't got our surgical one in place, we've got a status quo where actually we carry the risk of something that needs a surgical opinion, a surgical expertise, is going to get delayed because we haven't got a means of saying to the surgical team, you need to come here quickly to see your patient because this is your patient. So, you know, it's looking at what can arise if you haven't got one and getting that understanding. So I'm hoping after I've meandered through writing them and looking at one that I've recently done, it might give you a bit of an insight, and hopefully that'll help you for any that you need to write for the future. And I think we've got, yes.
Yay.
If you want to give me some feedback, that would be really nice. Thank you kindly. And I hope it's helpful for when you have to write ones yourselves. And I do believe the next session, which I'm quite looking forward to, I will be joining in on that one.
You'll be joining us for that, will you?
Yeah, because Brian's quite
Brian's an entertaining speaker.
Yeah, he's a good speaker. And art of negotiation.
Yeah.
Ending PJ paralysis and all that.
Absolutely. I actually asked Brian to do this one because he was a union rep once upon a time, a long time ago, and I remember him telling me how he used to approach negotiations as a union rep. So I thought, right, Brian, negotiation, and it's Nurses Day, so I'm sure he'll have something erudite to say about nurses and nursing.
Yeah, definitely.
It should be good.
So that'll be an excellent session to look forward to it.
Yeah, please don't be put out that it's more exciting than writing a SOP. Writing a SOP is less entertaining, but it's more useful.
It's a dark art, actually, writing a SOP.
Certainly is.
So yeah,
but
good luck
to everyone.
Very important.
Yeah.
Yeah.
Thank you, Marianne.
Thank you.